And this is a joint presentation with Donna da Costa Martinez. She will follow up after I introduce this topic. I have a disclosure to make. My institution received trial medication from Gilead, and that was for a PrEP studies that have been going on since 2015. Donna da Costa Martinez has no disclosures. So the term sexual health was mentioned by WHO 50 years ago for the first time. That was in 1975 in the publication you see here on the left side. And it's the first time that sexual health was considered something which does not only have to do with disease and negative connotation. What it had been mainly up until that time from the point of view of WHO, and unfortunately also today in many sexual health care settings across the world. And this is the updated definition of WHO, which you see here on the right side. Sexual health is considered a state of physical, emotional, mental, and social well-being in relation to sexuality. And what is very important is it is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility to have pleasurable and safe sexual experiences free from coercion, discrimination, and violence. And it's also around that time that you see a movement in WHO to move away from other specialized care topics, like, for example, leprosy, towards a more integrated model. Leprosy, up until that date, was very much taken care of in special leprosy hospitals and outpatient clinics, which were completely dedicated to the sole purpose of fighting leprosy. And that often parasitized other health institutions like general hospitals, for example, because they paid higher wages. So a lot of people only wanted to work in leprosy dedicated centers. And it's then when WHO also proposes to introduce community health workers as central figures in the fight against leprosy. And that's also what you see subsequently in the efforts of WHO to come to the integration of STI management, HIV, and family planning. In a sense, it's also coined a one-stop shop. And the reason is that since you have to do with overlapping key populations like sex workers and also men who have sex with men and transgender women, you could probably achieve more by creating multidisciplinary teams, which could create synergy in helping people who are in need of sexual health issues. It could also meet, in that sense, a shortage of staff when you combine fragmented services into a one-stop shop. And it can also improve adherence and follow-up because people do not have to move around and visit multiple centers to get the full package of what they need. And of course, it could be cost saving in that sense. So if you want to move from a classical model towards a more integrated service, you also take into account that there's a lot of diversity across the globe as far as how STI and HIV infrastructure is built in many regions today. For example, in the Commonwealth territories, you see a big influence coming from the United Kingdom, where in itself you already saw a form of integration with the establishment of the British Association of Sexual Health and HIV, the BASH, which is a merger from older organizations of the last century, like the Society for the Study of Venereal Diseases and the Association of Genitourinary Medicine. But for example, in the United States, both STI and HIV care is in the hands of infectious diseases specialists, whereas, for example, in continental Europe, where I work, you see that STI is part of dermatology. I myself am a dermatologist. And HIV is in most countries in the hands of general medicine specialists. And the picture in low and middle income countries is also very diverse. and partly built on the colonial remnants of infrastructure left by the colonizers, and of course the more recent developments into primary care and community health workers. So STI and a lot of sexual health topics are related to stigma, and that also affects the way that services are being provided and also taken up by those who are in need of sexual health. And current STI programs are in many settings still very stigmatizing. Targeting key populations makes them feel targeted and judged. So in that sense, and that's what Dr. Golub in an International AIDS Society meeting in 2021 also wanted to say, is that language does matter. When you speak about terms like targeting, it does have an effect on the population that you try to reach out for. And also focusing on HIV and STI risk is not an effective motivator for those who want to prevent themselves from these infections. Instead, sexual health should be promoted as taking control of your own health as a key population person. That's a sex-positive approach, as it is also coined. And from the side of the service providers, specialized services should try to normalize their care, like pre-exposure prophylaxis, HIV, and STIs. And one important topic is to de-silo these specialized services as they are now, as I described in the previous slide, and integrate them into comprehensive sexual health settings, which not in all cases do only have to focus on sexual health, but that I will address later on in the presentation. So Dr. Golub really emphasized that language, sex-positive and inclusive language, is very important to break down STI-related stigma. And again, warlike phrases as using strategies that target risk groups to overcome hesitancy, mistrust, and ambivalence should be rephrased into wording like strategies that identify what might motivate and support and inspire individuals towards action. It's not only language, it is also a way of thinking, and we should no longer see community members as targets, but more community members as agents in a joint collaboration towards a more sexual healthy population. And that brings me to the topic of key population-led health services. This is an idea that comes from Natia Panupak, who is a healthcare worker in Bangkok, Thailand, who started an outpatient clinic where she collaborated with transgender women and asked them, what kind of services would you like to be offered in a sexual health center? And one of the things that was found out is that especially hormone replacement therapy is something that transgender women are looking for and what was missing at that moment. So she started to also offer hormone replacement therapy and connect it to the other services that were already provided, like STI screening and HIV care. So it's a matter of to bridge the gap that exists at the moment between government services and key population, especially the most marginalized communities like transgender women, for example. And services should be identified by the community themselves and therefore should be need-based, demand-driven, and client-centered. And also, in the most ideal setting, be delivered by trained and qualified lay workers who are often members of the key population themselves in order to create a more safe environment that people like to visit to get their care from. We adopted this model in Amsterdam when we reorganized our sex worker and healthcare center, PNG 292. That's the address where the health center is located. It's close to the red light district in the center of Amsterdam. And we offer a variety of services to promote self-reliance and empowerment of sex workers. For example, legal assistant, we can help people to obtain their resident permit when they come from abroad. We have social worker who can help with employment, housing, and education, language courses, self-defense courses, and also sexual health courses. And for those who want to abandon sex work, there are also ways to help them achieve that goal. Psychosocial support, and we also focus on male sex workers and transgender persons. And of course, we also offer STI screening and pre-exposure prophylaxis care. So how can key population health services models improve the traditional STI service who are more established from a top-down approach? You see the gaps in the traditional STI service are often that they're inconveniently located. They do not match the service hours with the daily lives of those people you want to reach out for. They're fragmented and they have limited staff to respond to the needs of key population. Instead of those gaps, one should offer key community-based facilities in the hotspot areas where key population persons can be found. For example, as we did with a location close to the red light district when we wanted to reach out for sex workers. And also introduce flexible service hours, have clinics at night and in evening hours, which when sex workers are also on the job. And the one-stop service was already mentioned. How to address the shortage of staff can also be by recruiting key population persons, often lay persons, and have them on your payroll to relieve the limited staff, which we see, of course, in many healthcare settings. Of course, what is very important is the acceptability and also the quality, where we see now that in the traditional STI servers, there often are lack of skills with healthcare providers who can unawarely be stigmatizing and discriminating. When you have well-trained and certified key population community healthcare workers, they can provide safe and tailored accessible services free from stigma and discrimination. And it can also help you with the dwindling international fundings due to other priorities if you take the opportunity to generate domestic and local funding via civil society engagement. So with that, I'd like to conclude my part and switch over and give the stage to Donna to continue the presentation.
But before we move further, because what I'm going to do is really encapsulate what Henry has presented to break it down to what happens on the ground. But before we go further, I want somebody to tell me what they understand by integration. And I know we have a number of NGOs here, and I'm not going to call any names, so I want somebody to jump up and tell me, based on what you have heard, based on all the discussions that we've had over the last yesterday and today, we now want to have a real discussion about what happens in this instance in terms of, yes, Xavier, please, thank you. So where's your phone? Where's your microphone?
That were not historically available in a centralized way so others can access it, as opposed to focusing on just one service delivery point at a time for different things.
Thank you. You all agree? Okay, so basically, we've been talking about integration, but I don't think there has been enough focus on the linkages. And therefore, I feel that there cannot be an integration if we are not thinking about the linkages that have to be made. So, are we there yet? So for me, I think this whole integration process involves action at 3 levels. We're talking about the enabling environment, which has to do with the policy and the legal framework. We're talking about the health systems, and we've heard a lot over the last day and a half about health systems and how they integrate and so on. And we're also talking about the actual integrated service delivery system. So that integration itself really relates to the actual service delivery, joining programs, joining operational programs to enable several outcomes by using different modalities. And Henry actually pointed out some for us earlier, and using multidisciplinary service providers. Does that make sense? So therefore, linkages really refers to the broader human rights-based approach with integration as a subset of that overall approach. So therefore, we need to think about where are the synergies? What makes sense when we're looking at the policy and the systems and so on? And that we need to really give consideration to the services that we want to be linked and which can lead to public health, socioeconomic, and individual benefits. So that's where we're talking about sexual and reproductive health in the broader context and how we could integrate, because HIV is a sexual issue. STIs, all related. How can we achieve that? So linking the HIV and sexual and reproductive health is critical for really addressing the human rights, the issues around gender equality, and achieving health targets for the Sustainability Development Goals. And when we are looking at the Sustainability Development Goals, the four that really jump out at us would be SDG 3, which has to do with good health and well-being, SDG 5, where we're talking about gender equality, and SDG 10, where we're looking at reducing inequalities, and 17, partnerships for the goals. And this issue about partnerships is what is key to ensuring that this integration can take place. But integration is not so easy. You're talking about organizations coming together who have their mandates. There's this issue of turfism. People really, they're talking integration, but they want to hold on to their areas for their life. So that does not facilitate integration. We have to have a common understanding and look at the partnerships in a way that will really help us to integrate the services and promote good health and well-being for the people that we serve. The other thing that I think is important for us to understand is that, and I have, next slide for me, please. The next slide. You can just pass all of that very quickly. Just press, 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 and it goes away. Okay, and I'm not going to go through this because the whole essence of what we are speaking about has to do with the linkages. But what we want to do is look at the benefits of integration. And it is not an easy fix. Not when you have issues where for years people feel that they have built up their organizations and now you're coming to ask me to do this thing. You know, how is it going to work? Is it going to take away my prestige? How, is it going to take away the funding that I'm accustomed getting from my government and other donors and so on? So what this integration would really do is, in terms of benefits, is improve the access to and uptake of key sexual and reproductive health, HIV, and STI services. You would find that through this integration, and we talked a lot about stigma and discrimination this morning and yesterday, will actually help in the reduction of the stigma and discrimination. There will also be improved coverage because those people who are not accustomed or not comfortable going to standalone systems will see that through this, we talk about one-stop shop, but I think we should use a much better term than that. It's really more being able to access all the services related to your sexual and reproductive health in one place. But that really hasn't happened in reality. So I've known, for instance, that the family planning associations in the Caribbean in particular, there have been attempts to really integrate sexual and reproductive health with STIs, HIV, and so on. But that comes with a lot of challenges. As I said, there's downsides. We spoke about turfism. The integration comes at a cost. Are we considering that? When we start to integrate, there are those who have been doing these, those of us who have been working in standalone programs will begin to wonder, is my funding going to go away? How are we going to do this? So this normally is interpreted differently depending on where you fit on the scale of things. Sometimes it's perceived as an additional work for some people, because you're trying now to bring other services, let's say, into the sexual and reproductive health arena. You're trying to include in these services STIs and so on. But have we thought about the fact, and we say, oh, it's a good fit, but have we thought about the fact that we now have to retrain our human resources? There are financial and human resource implications, because the people who had been accustomed, the service providers who had been accustomed to doing, let's say, counseling and family planning, now have to think about on contraceptives, now have to think about the fact that they now have to do extra counseling on STIs, on HIV, and all the others that come with the package. And this is something that I think really is really not allowing us to move forward in a way that the whole service can be really one that is integrated. It's not often a one-size-fits-all. And it's also dependent on the political leadership. Let's not forget that. Right? It's also dependent on the political leadership. So while efforts have been made at integration in the Caribbean, which have been mainly done through the non-profit sector, the NGOs, we commonly call community organizations, not-for-profit organizations, non-governmental organizations, integrating HIV and STI testing with SRH services. One good example, and I have Angie, we see Angie in the room here. One good example is what happened at the Family Planning Association of Trinidad and Tobago, where we have worked with the key populations to actually help us to integrate the services. So they were trained, they were paid to do the navigation. So even though you came to the Family Planning Association for your STI testing, for HIV testing, or whatever it is, those members of the key populations who worked closely with us were the ones who were the navigators, who would take the next step and help them through the next process. So everything necessarily didn't happen. Treatment didn't happen at the Family Planning Association. But we saw people becoming more interested in utilizing the services because they felt it was a safe space, that they didn't have to come and people think, oh, that person has HIV and things like that. We were able to dispel those things. But you know the sad thing? We were very bad at documentation. We were very bad at collecting the data that would allow us to speak to the effectiveness of this integration. And I think we have to go back. We have to go back to come forward again. We have to look clearly at how we are going to work together. We also have to establish a respect for each other. We also have to understand that we are doing this for the good of the population. And therefore, how are we going to work together to develop these models in a way that is respectful, that takes into consideration all the efforts of the work that have been put in by the NGOs for all these years, and ultimately benefit the clients that we serve? You know, so I think this is something that I think we need to investigate more. What have been the models? What has been working in the family planning? And I talk about family planning because that's where I spent 27 years of my life. But how have we utilized the opportunities in order to ensure that the clientele we serve get exactly what they want? I know, for instance, that Chinlobi in Suriname, and I know we have representatives here who could perhaps give us examples of that, they're presently integrating PrEP and STI screening into SRH services. I know, for instance, that Haiti has a well-documented model called Gateways to Integration, and I think in the slides that you will get the link, and it's a case study from Haiti. What can we learn from our country counterparts that we can apply in our own individual situations to make sure that we've taken care of our populations? So basically, what are some of the take-home messages that as we go home, that we should take away from this workshop and try to create within our own programs? It's not going to happen overnight, and it's going to take coordination as well, not only in country but across countries. We're going to need support of the agencies that we have here present in the room, the PAHOs, the UNAIDS, all those organizations that for so long have been supporting us in the work that we do. How do we rethink our strategies to make it more effective for our populations? So some of the take-home messages would be our ability to mobilize resources and establish amicable partnerships, and I stress amicable, which are key in the SRH, STIs, and HIV integrated response. Strong partnerships and ample financial resources are critical. Another take-home message is that key populations, people living with HIV, men who have sex with men, transgender persons, people who inject drugs, sex workers, all of whom we've been talking about, how do we make them essential partners within the systems that we work? And as Henry said, nothing for us without us. For stigmatization to decrease, resources need to be invested in training service providers. And we talk a lot about that today as well, in understanding the rights of PLHIV and improving our interpersonal skills. So that integrated and coordinated linkages between SRHR and HIV services requires strengthened health systems, trusted partnerships, planning and budgeting, human resources, because I've been hearing a whole lot of talk that you already have the people in place. But have we given thought to the fact that some of these organizations have labor unions? Have we given thought to those issues? I'm finishing now. The procurement and supply chain and management, and monitoring and evaluation, more importantly. In terms of some of our recommendations, we have to do the work. We have to do the groundwork. Advocate, advocate, advocate for political commitment to an integrated SRHR and an HIV agenda. Are we talking to our ministries of health? Are we hoping that by some magic it will happen? We have to work with the political framework. Advocate for investment for strengthening and scaling up the integration process. We have to examine, review, and revise the national laws and policies that are not in alignment with the human rights approach and does not facilitate adequate access to services needed by key populations and others. We have to create a shared understanding of SRHR and HIV integration by building the evidence base and sharing research, good practice, and lessons learned. We have to promote these innovative approaches so that others can learn from them, so that they can build on those approaches, so that we can get more people into the system. And lastly, document and share the successful models of integration. So that is my summary in terms of the information which had been shared earlier by Henry. And then I think we'll take questions now.